Thank you, everybody. We've got the last talk now. It's really my honor and pleasure to introduce the next speaker, Professor Robert Anderson. Really, Professor Anderson needs no introduction. He is obviously world-renowned and a pioneer in the field of pediatric cardiac morphology, a person who has contributed immensely in refining the field of pediatric cardiology and improving the understanding of malformed heart. He has always contributed and has been an excellent teacher to impart knowledge even after retiring, to enhance our knowledge about the anatomy and morphology of the heart. He has always been leading in terms of obviously research, but also in terms of teaching, and he's an excellent teacher. And me personally have had multiple opportunities of listening to his lectures and learning a lot. Obviously, I would kindly request Professor Anderson if he could deliver his talk, which is based on future perspectives should the interventionist be closing atrial septal defects, which are not located in the Fossa Ovalis. Please, Professor Anderson.
In fact, my talk has been pre-recorded, so I think Rez has the wherewithal to start off, and I'm here to answer any questions you might have. Well, good afternoon to you all, ladies and gentlemen, and it's a pleasure for me to join you on this auspicious occasion, and I hope that all of you in Leicester are very happy in your new surroundings. It's very kind of you to ask me to talk to you about interatrial communications. Eventually, we're going to get round to talking about the sinus venosus defect. But I know already you close a lot of defects within the oval fossa using the interventional technique. But it is important to distinguish between those defects that are within the oval fossa and what we call still the sinus venosus atrial septal defect. Because in reality, the sinus venosus defect is an interatrial communication. So my focus this afternoon is going to be on differentiating true septal defects from the lesions I'd prefer to call interatrial communications. And that means, of course, we need to know all about the anatomy of the normal atrial septum. So I'm going to start off by sharing with you some thoughts about the normal septum, because that's equally important when you contemplate how safely you can close those defects within the oval fossa. So we need to start off by agreeing on what we are going to call a septum. And I'd like to suggest to you that a septum is a partition. It separates adjacent cardiac chambers, but it is a partition that you can remove without exiting from the cardiac cavities themselves. And this means that we have to distinguish such partitions within the heart from other areas that separate adjacent chambers but are folds rather than solitary partitions. So I'm going to illustrate that to you with other things that you are very familiar with, the ability now to show anatomy using computed tomography. I've been involved in this for several years now with a very good friend and colleague called Shumpei Murray. Shumpei came to visit me now several years ago, and he at the time was working in Kobe in Japan. He's now working in the University of California in Los Angeles, and he is a wizard at manipulating three-dimensional data sets. Now, I know you also do the same thing in Leicester, so you're going to be very familiar with the sort of pictures I'm going to show you and with what you can achieve using computed tomography, because it's now my belief that you can see the anatomy with just as much detail using these three-dimensional data sets as I can when I have the heart in my hands. So you'll immediately recognize, I hope, that you're seeing here the right side of the heart. And what Shumpei has done, he has sliced off the parietal walls so that you can see the septal surfaces. So there you see the focus of our attention, the oval fossa. And that is where we find true septal defects. But one of the beauties of the computed tomographic data sets is that we can cut them in any plane we want. So here I'm going to take a cut from top to bottom. You see it's going through the superior caval vein, coming down through the inferior caval vein. We then rotate it such that you can look at it from behind. So now you're seeing the right-sided chambers to your right hand, the left-sided chambers to your left hand. So there is the cavity of the left atrium, and there we see the cavity of the right atrium. And coming out of the top, as you would expect, is the orifice of the superior caval vein. Directly beneath that, the orifice of the inferior caval vein. And then now you see the space between the chambers. In life, of course, that is filled by the flap valve of the oval fossa. And so there's not really a hole in this particular data set because this comes from a patient with a normal heart. But all the yellow stuff that you see there is fibroareolar tissue, and that is filling the folds that are found superiorly. And although many people call that the septum secundum, it's not a septum at all. It is the superior interatrial fold, and you can see how extensive it is. And there underneath the oval fossa, we have the inferior interatrial fold. So really, when we cut it in this plane, the only true septal structure is the floor of the oval fossa. But this is the beauty, as I say, of computed tomographic data sets. We can go back to the original three-dimensional data set, and we can cut it in any plane we want. So here is an oblique short axis cut across the oval fossa. So now we are looking down on it. So the left atrium, again, is to our left hand. There is the right atrium, and now we can see how the right ventricle and the infundibulum swing round as the infundibulum exits from the heart. So there now we see the short axis across the oval fossa, and once more we see those folds that are forming its boundaries. And there is the superior fold, there is the inferior fold, and here now is the key for those of you who are closing defects within the oval fossa, because the major danger area right there in the middle of the heart is the aortic root. And you all know that you have to be very sure that there are sufficient folds for you to anchor on the device. I don't know which device you use, but whichever one you use, there has to be sufficient borders of the defect in order for the device to be properly anchored. And again, you get this key information using these three-dimensional data sets. But let's go back to our original view when we're looking at it from the right side, and let's take one more cut, because this now illustrates a particularly important point. It shows us the true second atrial septum. So here's the view that we see when we cut it in that direction, and now we're looking at it in what we would call four-chamber fashion, but we're looking at the four-chamber cuts in attitudinally appropriate fashion. So the right atrium is in front of the left atrium, and there now we see the oval fossa. But now we see that there is a true component that is interposed between the cavity of the right and the left atrium. And this is what I would like to call the antero-inferior buttress. And it is opposite that posterior fold. And it lies adjacent to the offsetting of the valvar leaflets, which we used to call the atrioventricular muscular septum, but we now know this is the atrioventricular muscular sandwich. And we can illustrate how accurate now is computed tomography when we compare that with a true anatomic presentation or dissection made by my good friend and colleague Diane Spicer and orientated in exactly the same way. So there at the back, you see the left atrium. In front of it, we have the orifice of the inferior caval vein, And there now you see the true second atrial septum. It's what I like to call the buttress. It is the myocardium that anchors the oval fossa onto the insulating planes that separate the atrial and the ventricular chambers. There is the oval fossa itself, and at the back you see another fold, which is now the posterior fold. And there is the offsetting of the hinges of the mitral valve on the left side, tricuspid valve on the right side, and that is in the area of the atrioventricular muscular sandwich, and those walls of the sandwich encompass the inferior pyramidal space. We don't have time to talk about that today, but the anatomy of the inferior space has again been clarified by access to computed tomographic data sets. So there it is, the muscular atrioventricular sandwich. So this is how I'm more used to looking at the anatomy and how I can show it to you as I would in the autopsy room. I don't think it's any better than what we've seen in the computed tomographic data sets. But there at the top, you see the orifice of the superior caval vein. At the bottom, we have the inferior caval vein. And now we can also see the third venous tributary that is entering the right atrium, the orifice of the coronary sinus. And that is the location of that antero-inferior buttress. Running through it, you have the extension from the eustachian valve that picks up the commissure with the Thebesian valve, and it continues as the tendon of Todaro. I'm sure you all know that the tendon of Todaro is one of the boundaries of the triangle of Koch. The atrial wall of the triangle of Koch roofs over the inferior pyramidal space, and there at the apex of the triangle, we have the location of the atrioventricular node. But what we are concerned about today in terms of what you do during intervention is what is surrounding the oval fossa. The primary atrial septum itself, the flap valve, is forming the floor of the fossa, but what is making up those rims? And Diane Spicer has shown you what's making up those rims by taking away in this heart everything that is not septal. So here it's the same heart. Might be difficult for you to appreciate that, but what she's done, she's cut away all the walls that are not septal. So there you see again the primary component of the atrial septum is the floor of the oval fossa. And now left behind there, we see that buttress of the atrial septum. As I say, this is the true second atrial septum. She's also cut away the floor of the oval fossa, and having cut it away, you see the fibroadipose tissue that is filling the cavity of the inferior pyramidal space. She's also cut away the walls between the opening of the coronary sinus, the opening of the inferior caval vein. And for a long time, we used to call that the sinus septum, but what you see filling that area is fibroadipose tissue, so this is yet another fold. But in particular, you can see that posterior fold, there is the fat within the fold, and they're all the way across the superior margin of the oval fossa. We see again the fat that fills the superior interatrial fold, and that is directly continuous, taking us into the interatrial groove, which is interposing between the oval fossa itself, and there in the top of the slide, the image, you see the aortic root. And that is the major danger area when you are introducing devices to close holes within the oval fossa. Nowadays, of course, you're becoming much more adventurous. So you've been closing so-called ostium secundum defects, and there's no reason why you shouldn't call them ostium secundum defects. You have to remember that the deficiencies within the floor of the fossa, however, are due to deficiency of the primary atrial septum, so they're ostium secundum defects, but they're not septum secundum defects. And I think it's much better when we're talking about these holes simply to describe them as deficiencies of the oval fossa. But nowadays, more and more interventionists such as yourselves are trying to close sinus venosus defects. So when we think of sinus venosus defects, we have to remember that these are interatrial communications because they are outside the confines of that oval fossa. And what I'm going to show you, and I'm sure many of you know this already, is that the phenotypic feature of sinus venosus defect is anomalous connection of the pulmonary vein or pulmonary veins to the superior caval vein, with those anomalous veins retaining their left atrial connection. And it is that retention of the connection of the anomalous veins to the left atrium that produces this channel that is outside the confines of the oval fossa. And we can see that very nicely when we go back to what used to be the gold standard, the lesions we see in the autopsy room. So I'm showing you here a sinus venosus defect. We're looking at it from above and from the right. So there is the superior caval vein, and you see one of the features of the sinus venosus defect. Because the orifice of the sinus venosus defect is overriding the crest of the oval fossa. There, however, you see that the oval fossa is intact, but you also see the phenotypic feature, because two of the right upper pulmonary veins are attaching themselves to the overriding superior caval vein whilst retaining their connection to the walls of the left atrium. And I've passed a probe through the superior rim of the fossa. I flipped the heart now, so you're looking at it from the left side. So now from the left side again, you see the overriding superior caval vein. There's another probe there within the anomalous pulmonary veins. The oval fossa is intact, and here is the key to understanding. Because I've been able to pass this probe from front to back through the superior rim of the oval fossa. Because the essence of the sinus venosus defect is that the superior rim, which initially is a fold, is converted into a tube of myocardium with fibroadipose tissue forming its floor, its core of it. So here now I've illustrated to you the morphology of the sinus venosus defect. And the key is that the oval fossa itself is intact. There is a normal arrangement of the primary septum, and there is the phenotypic feature. It is the anomalous connection of a pulmonary vein or more pulmonary veins to the superior caval vein, but with those veins retaining their left atrial connection. And it is that anomalous connection that is producing this conduit, which is a veno-venous bridge between the cavity of the right atrium, the cavity of the left atrium. And it is outside the confines of the oval fossa. And in doing so, in the creation of this veno-venous conduit, the anomalous pulmonary venous connection has turned what initially was the superior interatrial fold into this tube of extracardiac tissue, which has the fibroareolar tissue as its core. Now, there's no question that you can close some of these interventionally, but I don't think you can close all of them. And much depends on the extent of override of the superior rim of the oval fossa by the superior caval vein. And as you see, we've recently looked at 100 cases by computed tomography. There was no override, surprisingly, in 31%. 2/3, however, had what you expect, primary connection of the superior caval vein to the right atrium, but in 1/20th, the override was such that the superior caval vein effectively was connected into the left atrium. And this is work that I've been doing with my very good friends and colleagues at the All India Institute of Medical Sciences in New Delhi, and it's been coordinated by Sauram Gupta. And we hope to have this published very shortly. So these are the cases that are ideal for interventional closure, and it is when there is no override of the orifice of the superior caval vein. I'm showing you the picture from the right side again. There is the oval fossa. You see there are small fenestrations in the floor of the oval fossa. The lower pulmonary veins are normally connected into the left atrium. But there is the phenotypic feature. Here you have two right upper pulmonary veins. They are connected to the superior caval vein, but they have retained their left atrial connection. And it is that retention of the left atrial connection that produces the interatrial communication between, and they are entering the superior caval vein in such a way that they are miles away now from the superior rim of the oval fossa. And this is one of the exquisite computed tomographic images that have been prepared by Saurabh and his colleagues in New Delhi. And there in the red dotted line, you see that communication between the right superior pulmonary vein and the orifice of the superior caval vein. And that is the sinus venosus defect. So those of you who are closing these interventionally will be putting covered stents into the superior caval vein. And when you have no overriding of the superior caval vein, that is a perfect way of obliterating these anomalous connections between the pulmonary veins, the superior caval vein, but as I say, with those pulmonary veins retaining their left atrial connection. So Saurabh and his colleagues in New Delhi have looked very carefully at their 100 cases, and they've tried to establish how many would be suitable for closure. And at least 1/4 of their cases they consider would be suitable for closure. In a third of them, however, they think they would be unsuitable for closure, with the findings being equivocal in 2/5. And a lot has been written about this quite recently, but I would point out to you that, in fact, I was involved in the first instance of which I'm aware of an interventional closure of such a defect. It was done by my colleagues in the Medical University of South Carolina, along with colleagues in Toronto. We explored the background to all of this, and here you see the paper we wrote in 2011, 10 years ago now, when we described those veno-venous bridges. We pointed out that they were examples of sinus venosus defects, and the presence of these veno-venous bridges made it, in appropriate cases, an easy matter to achieve interventional closure. So no question, you can close the defects interventionally, but you need to be very aware of what's going on and what is the underlying anatomy. So, ladies and gentlemen, thank you for letting me join you this afternoon in this important occasion when you move into the new hospital in Leicester. I'm sure you're going to be closing several of these cases, but let's remember that when you are closing interatrial communications, it is only those channels that are within the oval fossa that are true septal defects, along with those much more rarer lesions which percolate through that anterior-inferior buttress of the oval fossa. And the other defects, not only the sinus venosus defect, coronary sinus defect, I've not had time this afternoon to talk to you about that. You can certainly close those interventionally, but they're not atrial septal defects. Neither is the ostium primum defect. The ostium primum defect, of course, is an atrioventricular septal defect. So what I hope I've emphasized is that they are outside the confines of the atrial septum. But I've also tried to emphasize you can now see this anatomy just as easily using computed tomography as I can show you when I have the hearts in my hand. So thank you so much for letting me be with you. And if you have any questions, I'm more than happy now to answer any you might wish to put to me. Thank you.
Professor Anderson, then why do we call them septal defects? Why don't we call them fenestrations? And why don't we call them windows, veno-venous windows? In order to be clear to our to us, the intervention is that we are not closing something in the heart, we are closing something outside of the heart between two veins, as it is the AP windows, for instance.
Well, I can't answer that question because I don't call them septal defects. It's you who has to answer that question. And it's you, I mean, you must know that for years, people such as yourself have ignored what I've been trying to tell you. I've been trying to tell you this for the past 40 years, and the more sophisticated of you have taken on board. And I'm sure Frances doesn't call them septal defects, or at least if she does, she's a very naughty girl, because I've been telling her not to call them septal defects for a long time. So your point is well taken. They are fenestrations. They are, there is another reason why you have such channels. So the coronary sinus that we had no time to talk about today, that is in essence unroofing of the left superior cable vein. And as I say, the ostium primum defect is an atrioventricular septal defect. That is a septal defect, but it is a defect of the atrioventricular septum in the setting of a common atrioventricular junction, rather than an atrial septal defect.
In the series of studies that they have done, approximately 32 cases, I believe it was published from Evelina, and a second series from another center, I don't remember the center. They have shown that they didn't have any kind of problems from sinus node. So the rhythm was not disturbed. So in these cases, in days that they are suitable, the 27% that you said, the sinus node is far away from this area that we are putting the stent.
Well, one of the troubles with the results that have appeared from the Evelina is that they haven't really taken, they haven't looked. You probably know more about their experience than I do, but I don't think they have looked at the potential cases with the detail that Saurabh Gupta and my friends have looked at it in New Delhi. But you are correct that you could draw the inference that the very fact they had no sinus node problems would suggest that in fact the defects were, as in the second picture I showed, a long way from the superior rim of the oval fossa itself, with no overriding of the superior cable vein. Those are the ideal ones for closure, as I mentioned, and in that instance, the channel between the chambers is well superior relative to the oval fossa, and on the opposite side from the oval fossa is the terminal crest, and I fancy that they are well superior to those always. I don't know if you were able to close some with a small degree of overriding of the superior cable vein, whether in that instance the covered stent would impinge on the sinus node, because the sinus node is on the epicardial aspect rather than on the endocardial aspect of in the terminal groove. So I don't think you would necessarily directly impinge upon the sinus node, but you are correct to mention that feature, because that would be an added reason to be careful for fear of damaging that are more superior with the defect well away, and as you say, away from the cavity of the right atrium, probably still within the pericardial cavity, but much closer to the boundaries of the pericardial cavity.
Thank you very much.
Professor Anderson, always an excellent talk.
How are you? Nice to see you. Good to see
great.
you.
I can sense a paper in the making by some bright young guys on classification of sinus venosus defects. Type 1 to type whatever.
Oh, please not type whatever. As you know, I hate alphanumeric categorizations, but you make a good point that we could well have a categorization of the different types of sinus venosus defects, because it is, I think, an important differentiation to make. And I have to confess, I hadn't thought about the danger of damaging the sinus node. And it's a very good point that has just been made, because when the closer the defect to the superior rim of the oval fossa, it does follow that the sinus node is potentially at risk. You must have closed a fair number. Have you closed some yourself?
Nope, not here yet.
Not here.
Has Sebastian closed any in Poland? Is Sebastian still with us?
Sebastian, you're muted.
Yeah, I'm with you. No, I haven't had that experience here in Poland, and I just missed that Evelina experience. They started doing that after I left, so you know, it sounds interesting, and the day will come. And I'm happy to use 3D imaging for that.
Oh, well, the points you made about 3D imaging. I mean, in many ways, what you're talking about, superimposing the 3D imaging on when you're doing it, that must be a great advantage to judging the adjacency and how close you think a covered stent might come to the sinus node and the terminal crest.
Yeah.
I've done 2 adults with a rather slit-like or bean-shaped deficiency or communication. And I actually went through the mitral valve and put a covered stent into the pulmonary veins, connecting the pulmonary veins to
right.
And so to redirect it. And I wasn't bothered about a small residual left to right shunt.
How long ago did you do that?
8 years.
Yes. So, and in many ways, that's the alternative way of doing it, isn't it? Because if it's a veno-venous bridge, you can either attack it through the superior cable vein, or as you say, you can do it through the pulmonary vein.
Yeah, but also if you then end up with SVC narrowing, you still got the beauty of the azygos vein, and it just goes down.
Indeed.
Yeah.
I mean, it's a good point, and in many ways, that might be the safer way of doing it, might it not? Because
even if you end up with a tiny left to right shunt, it doesn't matter.
And I presume you didn't report those cases.
No, I didn't.
So many things you've done, Oliver, without reporting them.
Yeah,
You should dig them out, and you should, because I think that is another important point, that you can do it from the pulmonary venous approach as well as the systemic venous approach.
Yes, and I think it would be more, to me, it's more logical.
It is. Would you have more problems with access in children compared to you doing it in adults?
Yeah, there were adults.
But would it be as easy to do it in, let's say, a 5-year-old or a 3-year-old to go through the mitral valve?
Well, probably 8 years. I think 25 kilo at least.
Yeah.
Maybe in the new time that we have we have covered stents from different companies with small sizes that a child could take, and you can increase a little bit in the future. Maybe it would be possible to do it below to children, but I don't know if it is rational to put a stent in a child that's in a pulmonary vein of a child that is growing up, and you don't know where it will end up, and suddenly you realize that you lose a part of the lung, of the right lung, in that way.
Yeah, no, sure. But when you look at it also, when you look at CCAP data, the number of surgical ASD closures in adults has increased.
Yes.
And that is only because suddenly there's greater awareness of sinus venosus ASDs, or right heart volume load and more sophisticated images. The vast majority of sinus venosus ASDs now coming forward are actually in adults.
Yes,
and
that is true.
Yeah.
And do you not have biodegradable covered stents yet?
No.
No.
Ahead of the time, Bob.
But it must be feasible to create a biodegradable covered stent that would endothelialize itself into the pulmonary vein or the superior cable vein. Wouldn't that be better than putting a metal stent in?
Sure.
Of course it would be, but the studies or the biodegradable stents that we have, magnesium stents, and all of these, they have not shown so good, I would say, results, outcomes after that. So most of them, they have restenosis, endothelium proliferation. So they have caused problems there, unfortunately.
Well, somebody must be able to get a patent in there and make a biodegradable stent and become rich. Chen must do that. Chen must have connections over there in the USA.
I hope so. You give me an idea.
Biodegradable stents, Chen?
Well, I think seriously coming to that, maybe the alternative would be to use extracellular matrix, which the surgeons are using, where it has an attraction of attracting stem cells that will evolve into whatever structure you want it to be. So, but unfortunately, the scaffolding will still be non-biodegradable for now.
Right. Okay.